Christopher Horn is a senior public health leader and an Australian trained and registered radiation therapist. Christopher leads the delivery of the bowel cancer screening program for New South Wales. He has worked clinically in Australia as an advanced practitioner, and he is a fellow and a New South Wales president of the Australasian College of Health Service Management. Christopher, I hope you feel welcome. Please, everyone, make you feel welcome. Thank you.
Thank you very much for that warm introduction. Will you hear me okay?
I don't think it's on.
There we go. Yes. So, good afternoon, and can I say Aasha. Thank you for the kind invitation to speak this afternoon and for taking the time to be here. I would also like to, before I begin, acknowledge the traditional owners of the land that we're meeting upon today, the well-enabled people of the Eora Nation, and pay my respects to elders past and present, and any Aboriginal people who may be joining us today. And I'd like to just recognise Aboriginal people's continuing connection to land, country and water. I have a real affinity with the western part of Sydney. My background, as mentioned, is as a radiation therapist. And when I finished uni up in Newcastle, I interned at Westmead Hospital. I worked in paediatrics out there and worked there for about 4 years. I lived in Westmead and Northmead before I moved to the UK. So this part of the world for me is full of friends and family, and it's a place that I know, and a place that I know has a really deep sense of community. And has undergone rapid growth and change in the last few years, and I'm going to talk a little bit about some of those changes today. So I'm here to represent the Cancer Institute New South Wales. We are a pillar of New South Wales Health, so we support the hospitals to do the care that they do and the clinicians to do the work that they do, and we are essentially a one-stop shop for all things cancer. Can you hear me?
Lights off.
Lights off. I'll leave that to someone who knows what the lights are. The Cancer Institute has carriage of the screening programs for New South Wales, so the breast, bowel and cervical screening program, as well as the cancer registries. And we fund and lead a lot of the, or enable a lot of the research that goes on in New South Wales as well, and support fellows. We are working to improve cancer outcomes in New South Wales across the whole cancer spectrum, from prevention through to early detection, all the way through to treatment and survivorship. Multicultural communities are a priority population for us. Now, we do use CALD, which is culturally and linguistically diverse, and multicultural as kind of catch-all terms, but I think there's an easy sort of slip in that, because the important thing for us to remember, I think, all the time is that there are really important nuances, even between one group of people from one country, is that there are nuances between language groups and religious groups and different people who have different experiences, come here with their own beliefs and strengths. And importantly, in the work that I'm going to talk about, the stigma that they might have around cancer or around preventative health or screening for things like cancer. So, bowel cancer in New South Wales is a kind of a grouping of cancers, so cancers that arise in the colon or the rectum, is actually kind of frightening. It's the second most common cause of cancer mortality, cancer deaths, in New South Wales and in Australia more widely. But people are not as aware of it as they might be breast cancer, prostate cancer, and many other cancers like lung cancer. It disproportionately affects us as we get older. What we see is that more than 9 out of every 10 cases occurs in somebody over the age of 50. So it really is a disease of ageing. In New South Wales this year, we expect there will be almost 6,000 cases diagnosed in New South Wales, and around 1,770 deaths. So there's about 34 people per week who are going to die of bowel cancer in New South Wales this year. So they really are tremendous numbers. People are looking at a chance of bowel cancer of maybe 1 in 12 by the time they're 85, which means probably 4 to 5 people in this room alone. So it is common. It's important to note that bowel cancer often doesn't have any symptoms or signs at the early stage. It can do, and if you ever see any of these signs or symptoms, it's really important to talk to your GP about them. They can be things like blood in the bowel movements, so you might see blood on the toilet paper or blood in the water after you've done poo. Could be unexplained and ongoing tiredness, That could also be a sign of iron deficiency, which may be caused by a cancer in the bowel, stomach pain, sudden persistent change in toilet habits, or unexplained weight loss. Now, what you will notice about a lot of those symptoms is that they are very general. They don't point to any one thing in particular, and that's part of the reason that it's often not detected early. By the time people have symptoms that point towards bowel cancer, it can be quite late. And that's really an important factor in the outcome. What you can see on the left, I'm going to simplify this. This is what we call survival, but it's really the chance of treatment success. So what you can see on the left there is the earliest stage of bowel cancer. And if we pick it up at that earliest stage, just after it started growing, we have a 99% chance of successful treatment. You can see that tapers off. And by the time we get to the latest stage, stage D, stage 4, whatever you want to call it, for our intents and purposes, they are all similar enough. If we're in that latest stage, those statistics drop to about 12%. Now, I know if I was going to have a conversation with the doctor, and a lot of people will, to say that bowel cancer has been detected, I want to be in that first group and be told that I've got a 90 to 100% chance of success rather than the 10% group. So I did a little bit of research before I came today to find out more about Aasha, and I found out that it's named after what I believe is a Sanskrit word that means hope. So I think it's really important to note as well that for all of those frightening statistics I've just given you, there really is a silver lining to this. We do have a way to pick up bowel cancer when it's in its early stage, before symptoms appear, when we can successfully treat it at 90 to 100%. And in fact, this test can even pick up the changes that can happen in the bowel before they have turned into cancer, so that that investigation can happen when they are just small growths and have not yet become cancerous. So that test, and there's a kit up the front I saw, as well as a national bowel cancer screening program test. So that gets sent to people between the ages of 50 and 74 every 2 years, and it is important to do it every 2 years in that age group. And it's looking for not specifically cancer, but signs that cancer may be there. It's looking for microscopic amounts of blood that might be getting shed in the poo when you open your bowels and have a bowel motion. The test is clean, it's simple, it's easy. And we know that currently about 2 in 5 people do the test, about 40% of the population. That alone is anticipated to save 17,000 lives over 25 years just in New South Wales. If we could get a few more people to do that test, 3 in every 5 people who are invited to do the test, that's 25,000 lives in 25 years. It is one of the most cost-effective and significant public health interventions that we have in Australia and most of the world. It costs about $2,000 to $3,000 to save a year of life with this program, which is unbelievable. These kits are sent free to people at the home address, and in a recent change to the program, GPs can now give these kits out as well. So when you visit your GP, if they don't know about it, you can let them know that they can now go and log on to the National Cancer Screening Register portal. If they go to our website, which I'll give you at the end, we'll be able to link them off to that so that they can do the training and they can give the kits out to people in that age group if they need to do a screening test. So this is what the kit looks like when you open it up. The kit, the instructions at the top, 2 toilet liners that are completely flushable in any toilet at all, even septic systems, they will completely biodegrade in those systems. 2 tubes at number 3 there with little sticks. Now I said the test is quick, clean and easy. If people do this test, if they get invited for the first time, they're really unlikely to do it, we find. But once they've done one test, they are 84% likely to do it again. 4 out of every 5 of those people will do the test again, because once they've done it, they realise it's not that hard. They don't have to touch their poo. You literally put the liner in the toilet, take the kit into the toilet with you, undo that little test tube. After you've done a poo on the toilet liner, just scrape it through the surface, the stick through the surface of the poo, pop it back in the test tube, give it a little shake, and put it in a little hidden bag. Best place to put it is actually the fridge, but put it somewhere cool where it's not going to be exposed to heat. So there's a privacy bag in there. It is I have done one myself. I can guarantee you it's a really simple test to do. Comes in a reply paid envelope. So you can just stick it back in the mail after you've done it. You need 2 samples. So you do one on a bowel movement, and then the next time you go to the toilet, you do that one as well. Pop them both in the reply paid envelope, and then send them back with the form. So I should have stepped through this as I spoke. These are the steps involved. The hardest thing you're going to find is probably writing your details on that little test tube. I do apologise for that. That feedback has been given. You might need to find somebody with really good eyesight to be able to do that. It's a little bit small, but that's the hard part. So I just want to talk a little bit about the Indian community in New South Wales as well, because I think there have been some really dynamic changes in the Indian population and the language groups that we have. People born in India and living in Australia in the 5 years to 2021 has increased by 45%, up to 210,000 people. That's more than double any of the other country of birth population groups that we have, according to the Australian census data that we've used. Now, of those 210,000 people, 14.2% of them are within the bowel cancer screening age range. So that means if this doesn't affect you, then it does definitely affect your friends, your loved ones, and the rest of your community. While in terms of language groups, particularly while we see that the Nepali language had the greatest growth, Punjabi, Hindi was 8th and Tamil was 9th. And if we take those three alone together, that language group is far bigger than Nepali at almost 172,000 people, and it grew by 32%. A significant strength of the Indian community I've always found in my interactions is general language aptitude. Quite often speaking many languages, but particularly great English. Typically we know that more than 90% of people making up most of those language groups don't have much difficulty with English. So, I mean, that makes accessing information a lot easier, but in fact there's quite a lot of in-language information available as well. In terms of geography, the biggest concentration is in Western Sydney, with more than 50% of the Indian-born persons in New South Wales living within the Western Sydney area. So that includes 47% of Sinhalese speakers, 55% of the Punjabi speakers, 62% of the Tamil speakers, and 71% of the Gujarati speakers in New South Wales are all in that Western Sydney area. So obviously, as I said at the start, really integrated and strong community vibe there as well. If those stats don't really tell you anything, and that's fine. Many people don't like stats. I'm trying not to give too many, but I think some of these numbers are really quite impressive. If they don't tell you anything else, then there are 3 messages that I want you to take away from today. Bowel cancer is serious. Bowel cancer is something that you can do something about, and that there is a significant community here that needs you to start conversations and encourage each other to do the test. There is so much stigma around bowel cancer, and I'm going to touch on some of the barriers as well. So much stigma that is sometimes about talking about cancer, not wanting it in the family, not wanting to go looking for things that you don't want to find, not wanting to talk about bowels, poo, testing it, going to the toilet, any number of things. There are so many of those things that can possibly be. In fact, the only way to bring down those barriers is to start talking about it, how important it is, what a good news story it is that actually if we do go looking for it, we pick it up early, we can treat it. Go on living your life as if it barely even happened. It's possible if we pick it up early that you will wake up from your colonoscopy if you need to have one after a test and be told that we found something, we're pretty sure we got it all, you've probably not got anything to worry about. What a great news story though, rather than having around in 10 years and then find out that you've got something that we can't treat. So there are a number of other barriers people might face lower within screening programs. The concept of looking for things, early detection and public health sometimes is a really foreign concept for people, but it's really important that we talk about that and do maintain our health, not just react to things when we're unwell. There can be language and literacy barriers, embarrassment, shame and privacy. I guess one of the biggest ones that I see and one of the most critical is self-exemption. People thinking that this doesn't apply to them. And I'm sure there will be people in the room right now thinking that they don't eat meat and they don't drink and they do lots of exercise and therefore they don't need to worry about this. I want to really hammer home the point that the biggest risk factor that you have, if you don't have a strong family history, the biggest risk factor you have is age. It is being over the age of 50. Not eating meat, not drinking alcohol, having a healthy diet, living a really good lifestyle, those things will do wonders for a whole range of chronic and complex conditions and many other cancers. But for bowel cancer, it is age. You cannot escape it. Once you are over 50, you need to be screened for bowel cancer every 2 years. So we do a lot to try and support communities to increase screening as well as part of a wider institute to try and support people through that cancer journey, but particularly in the screening part, we aim to enhance the knowledge of those barriers. up, we can engage with the community and help out. We try to improve the data and the insights that we have, again, to help us kind of target messaging and let people know what they need to know to look after themselves. We develop quite a lot of in-language resources and delivery of community education. One of those is through the bilingual community educators and other community groups. Through some small grants that we do, and the flip charts, which you can see Sheetal's popped up the front for us here. This is a method of allowing people like bilingual community educators or organisational representatives to talk through the importance of bail screening in quite a diagrammatic, pictorial kind of way that's a bit more easy to digest if this conversation is a brand new one for somebody, but still contains all the relevant information for them as well. We're quite proud of this. This is co-designed. It's in about, I think it's more than 17 languages now. This is an example of some of the training sessions that we've had. More than 13 languages. There's an accompanying facilitator manual. We have trained nearly 200 community educators and 30 different organisations who've taken part. We've reached over 1,000 people, a few thousand people just with this initiative alone, through community partnership, through being able to come and speak to people. Now, I might be the one standing up here talking today, but it's you who's going to have the power to bring this up with your friends, your loved ones, your community, and talk to them about how important this is and spread that message. The cancer screening is something that can really change lives. We have a few resources. The one I would particularly recommend you use is dothetest.com.au. We very intentionally gave it an easy handle to remember. Dothetest.com.au. That is essentially a place you can go that will link you out to the things you need, or it will have the video there on how to do the test. There's lots of resources there for you and lots of frequently asked questions at the bottom. There's also some national program resources at health.gov.au, MBCSP translations, lots of different language options there as well. There are a lot of resources, and we've also got the cancer screening booklets, the brochures on the front, fact sheets in a great deal of language options there as well. So I would like to thank you very much for listening today, and thank you for the kind invitation. I think I'm on the panel and really well. Shukriya.
Thank you, Christopher. Another warm round of applause for Christopher, please, ladies and gentlemen. There were a couple of small pieces, small takeaways there, just as our next speaker comes up. But something that I got out of that was that this is serious. People around here that look at me, I'm one of you guys. Yes, I'm Australian, but by birth, I was born in Bombay. I'm a Maharashtra boy. I've got Spanish lineage in me, and I've got Portuguese lineage in me, and a lot of those categories, unfortunately, this sort of stuff is quite important. Has anyone here done the test that Christopher was talking about? Fantastic. You know what? In a lot of groups, sometimes when you sit around and have this chat with our cultural group, you don't get as many hands like that. Fairly simple to those who've done the test. Fairly simple. Very simple. How was the writing on the test sheet, as Christopher was saying? Is that all right? That was all right. Wasn't too bad, Christopher. All right. Our next keynote speaker, we've got Dr. Mohan Ariana. Dr. Ariana Yagan is a urological surgeon who treats cancers and other disorders of the urinary system, specialising in bladder cancer surgery and minimally invasive surgery for cancers of the kidney. Dr. Ariana Yagan is a training supervisor at Nepean Hospital and chairs the robotic committee that also oversees robotic surgery at Nepean Hospital. Ladies and gentlemen, I'm sure you'll make a warm welcome for Dr. Ariana.
Is that okay? Yes. All right. Thanks for the introduction. It's Ariana Yagan, by the way. No, that's okay. That's the Australian pronunciation. That's okay. Don't worry. No, as long as there's no expletives, I don't know. So look, I'm going to talk a bit about prostate cancer. The number one thing is actually about the screening, which follows on from what Chris was saying. Most cancers don't have any symptoms until it's in a situation where you're in trouble. So that's why there are various screening pathways for bowel cancer and prostate cancer. Some cancers don't have screening pathways, but basically if you notice something that's not right, go and see your GP and get checked. And so one of the other things for bowel cancer is actually just a change in bowel habit. So suddenly things start changing. Don't wait for the blood, go and see the GP. Now, prostate cancer is very common. It's the most common cancer in men, or it's the most common cancer in Australia, excluding non-melanoma skin cancers. So it is very, very common. And now we're looking at bowel cancer as 1 in 12. This is 1 in 6. All right, so it's twice as common as bowel cancer. Now, that all prostate cancers don't need treatment, so this probably overcalls it a bit because there are many prostate cancers we can just observe. But it is common, and you need to get checked. You need to test you to find out which one you need treatment. So should I get screened? The answer is obviously yes. If you have no family history, it's from the age of 50. If there is family history, it should be from the age of 40. And you'll have to forgive my dirty cartoons all the way through. Because urologists have vile senses of humour because of what we do. So when we say family history, we don't mean that your uncle had it at the age of 95. We mean first-degree relatives. So uncles, fathers, brothers, and also particularly in the younger age group. So the basic thing is talk to your GP and get tested. The GPs are now screening a lot more. They were not before, but their guidelines have changed, which is very, very good. So basically, if you're not sure, ask your GP, but from the age of 50. So everyone here who's over the age of 50 should have had a PSA, which is the blood test. As we've discussed, there are no symptoms when prostate cancer is at a fixable level. However, when you do get more advanced cancers, well, we can't really do a huge, there are plenty of things we can do, but it changes from being easily curable into a much more difficult situation. So you can get pain, blood and urinary issues, and so on. If it spreads to the bones, that's when it's metastatic, and we can't really fix it. That's even worse, and you can get back pain, bone pain, and so on. So what is screening? Screening is actually the definition of screening, is in testing people who don't have any symptoms. And that's what the message is really for all cancers is when there's a screening program, go and use it. Whether it's cervical cancer, breast cancer, prostate cancer, bowel cancer, go and get tested, follow the guidelines. You don't need to do more than the guidelines, just do what the guidelines say because they're evidence-based and they strike the balance between over-treatment and over-diagnosis and actually finding it at the right time. So the main thing for prostate cancer is getting a PSA done, and some GPs do a prostate exam, others don't. The guidelines say they don't need to do it, and that's because they hardly do it, and there's really not a huge amount of use in them doing it. The main thing is just get the PSA done at the appropriate time, which is when you crack 50.
What is PSA?
It's prostate-specific antigen, which I've got a slide on that. Oh, here we go. So that's another one. I don't know if anyone remembers Chuck Norris. Oops. So I'll come to PSA, Dr. Sundar. But basically, all the guidelines tell you get screened. All right. So the Prostate Cancer Foundation, the NHMRC, the Cancer Council, everyone is telling you to get screened. So it's not like it's just a urologist saying go get screened so we've got some extra work to do. It's from the guidelines, right? Which we have been involved in but not written. So what is PSA? It is a blood test. That's all it is. So it's very simple. And I tell most of my patients who are healthy, you should see your GP at least once a year, pick it around your birthday so you don't forget, get everything done, cholesterol, blood pressure, kidney function, and get a PSA done. Now, PSA is a protein in our ejaculate, and a little bit of it always leaks into the bloodstream. So if the level in our bloodstream is higher than it should be, or if the level in the bloodstream is going up faster than it should, then you need to get tested. So usually your GP will do those basic investigations, and if they find that the PSA is high or going up, they will then refer you to a urologist. Depending upon your age, there is a different level of PSA that is acceptable. All the different labs have this, and this is freely available on the internet. And This is just from Douglas Pathology, the one that I use, but each lab has something similar. So high PSA, the most important thing to actually remember is that if you get sent to a urologist with a high PSA, we only find cancer in about 1/3 of those patients. So you actually don't need to be overly worried that because a lot of patients have other things that can cause the PSA to be elevated. And the most common thing is actually a urinary tract infection. And so I get a lot of patients who turn up in an absolute panic because their PSA has gone up, but it was done when they had a urinary tract infection. So you just treat the UTI and monitor the PSA, and it all gets better. So it really doesn't matter. There are drugs that can lower the PSA as well. If you've got a big prostate, the PSA can be high. So you can see that there are a whole range of reasons why the PSA is not actually, an elevated PSA does not necessarily mean that one has prostate cancer. Obviously, the higher the PSA, the real PSA, not the PSA in the setting of the infection, but the higher the PSA, the higher the chance of cancer. If you have a high PSA and you also have an abnormal prostate exam, then the rate of cancer is going to be higher. But again, for us, this is something, one of the pictures I show the medical students, but really, as people in the community, the main job is just go and get tested, let your GP do the rest because they know what they're doing. So what do? When you have a high PSA, I always repeat it, and I also do a prostate exam. And if there are various criteria for an MRI scan, and if the MRI comes back showing something, or there are various other parameters, the PSA density, for example, I do a prostate biopsy. Who gets an MRI? It's got to be ordered by the neurologist to actually get the Medicare rebate. And there's a range of specific criteria. Now, some patients want an MRI before they come and see a urologist. Well, they may not need one, but some people just say, I really, really want this. Well, they go and have it done, but they have to pay for the whole thing because they don't meet the Medicare criteria. So again, with all of these things, it's best to be rational, and there's an well-established pathway, which means you come see one of us, we'll do all the testing, we'll determine whether or not you need one, and if you need one, then you'll get it. And that's the sort of, we get a report with lots of pictures on it, which are very difficult to interpret, but the guy that I refer everyone to gives me a nice cartoon picture showing me where the problems are, and we get also a score for the abnormality that we find, and after that we'll do a biopsy. So if any of you have had a biopsy in the distant past, it was horrible because you were awake, you had some local anesthetic. These days we don't do that, and so the patient is anesthetized and they have a biopsy using this approach, which is called a transperineal approach. The added benefit is that the risk of infection is very, very low. So it's less than 0.1%, touch wood. Now, if you were to read about things in the media and Google prostate biopsy, you will hear about horrible episodes of sepsis and infections and people dying and all sorts of things. That's from the old one where the needle went through the rectum into the prostate. So the infection rate was 5% or thereabouts, and with increasing antibiotic resistance, it could be quite lethal, especially if people who travel to Asia, which would be all of us at different times, because we pick up bugs and then we come home and have our biopsy done and the antibiotic didn't cover us. Using this transperineal approach, it is very, very safe because while the ultrasound goes in the bottom, the needles go through the skin behind the scrotum, which is painted with PrEP and iodine, and it's very safe. So if you need a biopsy, please don't panic, because one, you'll be asleep, and secondly, it's very safe. This is another kind of biopsy where we use MRI fusion. I left it in there mainly because the picture's kind of cool, but we can target the MRI lesions very accurately. So it's actually, technology has really made a huge difference, even in my short career. Treatment options, I could bore you to tears with all of this, but basically there are lots of different treatment options, and the goal is to target the treatment to the individual patient, depending on what kind of disease they have, what their scans show, and also their choices. And so yeah, we target things based on so many different factors. So it's individualized treatment. that we offer patients. I mean, of course, being a surgeon, I'm totally biased because I think that surgery is the best option. But we do refer to a range of people so that you speak to the radiation oncologists as well, and everyone is fully informed before they make the decision that's right for them. For some people, it's a no-brainer. We say this is what you need to do, and these are the reasons. For others, they have a lot more choices, and we may give them time and help them make that choice. So the key point here is that get screened, the excellent cure rates. So when we find prostate cancer at the right time, the 5 years of disease-free survival is like well in excess of 95%. So just like bowel cancer, if it's found early, we can fix it and you'll be fine, which is something, I sound like a broken record when I tell my patients that, mainly when they walk out, telling them if you remember nothing else from this first discussion where I've told you you've got cancer, just remember, we'll fix it and you'll be fine. But if you turn up with a PSA of 1,000 and it's in your bones, it's hard to be as positive. This is just a bit of fun. Basically, robotic surgery is what I do. We've got robots in the private and also the public. That's the newest robot that we've got called the Da Vinci Xi. There's a bit of a cartel going on because it's only one company that's had the monopoly for the last 20 years. But now there's about 30 companies that are coming out with new robots, and I'm confident we'll be able to use those. The prices will drop as well. It'll become more and more accessible for every hospital. Why robotics compared to open, which is what we used to do? It's a no-brainer because as a surgeon, it's just so much easier to see, there's less blood loss, and we've actually got a meta-analysis, which is a very big study which showed less blood loss faster, you get dry faster, you go back to work earlier. So, I mean, it's a no-brainer. So I'd just like to finish off just showing you a couple of little videos of some robotic surgery. And this is showing the prostate over here, and this is the nerve bundle. This is what supplies our erections. So this shows how I'm sparing the nerve, and you can see this big veil of tissue down here, and that would be the nerve. And again, you tailor it to the right people and the right patients, but that's just how the robot works. And the robot gives me 7 degrees of freedom for each instrument and 3D HD vision. So it's very, very, very useful. This shows a lymph node dissection, and you can see this huge vein here. This purple thing is the vein that comes up from our leg, called the femoral vein, the common iliac vein, external iliac vein, and that's a big node packet there. And you can see that huge vein there, right? So making a hole in that'd be bad. But it's just to show you, really. You can do it. Basically, I can pretty much do any operation that I could do open, I can do it, or laparoscopically with keyhole surgery, I can do with the robot. And then here's a picture where once the prostate has been removed from the pelvis, you've got to join the bladder and the water pipe back together again because there's a bit missing from the middle. And you do that with with the robot again by suturing. Does that work again? So, and again, I'm stitching things together. And the beauty of this is I'm sitting nicely on a console in an ergonomic fashion without breaking my back, ruining my neck, which is what happens to us when we do these things open. And that's the bit at the end there is the urethra, and this is the bladder, right? So I'm joining everything up again, and this is a special suture which has a little loop. It's a barbed suture, which means that it doesn't slide back when I stitch. So I can pull it tight. So this sort of came in when I did my training in Australia, and then I went off to the States for a couple of years, and that's when I started doing this. I've been doing this since 2009. I've been doing robotics, and it's now become very commonplace. So when I came home, I felt I was allowed to feel a bit special because very few people were doing it, but now everyone does it. And at Nepean Hospital, which is my public hospital where I do a lot of teaching, we teach the registrars how to do this, and so they're all very experienced when they finish. Then they usually go overseas for another couple of years, just like I did, and go and do some more work, so that usually when you've got someone coming back, they're really well trained. didn't speed this up enough. But anyway, you see that little tube, that's the catheter, that's the water pipe, and that's the bladder getting joined on. I'll skip forwards a bit, and you can see I'm just stitching away. Most of cancer surgeries, chop out the dodgy bit, join everything up again, and hope like hell it works.
How you remove the bits you cut?
We put it into a special little bag, which we then pull out through one of the incisions. And see, it's almost joined up. Now I'm doing the top part. Oops. Anyway, that's how it goes. And I guess any questions?
When you say robotic, you are using the robotic arms. You are controlling.
Yeah, it's basically robotic suggests that there's some degree of autonomy, which there is not. So it actually would be better described as being a computer-assisted surgery, but robot sounds much more fun.
What is the urodynamic study?
Sorry?
Urodynamic study.
Urodynamic study is different. That's a different area of urology on avoiding dysfunction, where people can't urinate properly. And we put tubes into the bottom and into the bladder, and then inflate and measure pressures to look at whether their bladder function, what their bladder function is like, and also whether they've got blockage or not. So it's nothing to do with cancer, and I don't actually deal with that at all.
It's not linked to the prostate.
It can be linked to the prostate, and it can be linked to benign prostatic enlargement, which leads to bladder outflow obstruction. So all of those things happen, but as I said, that's an area of urology we call voiding dysfunction, and you have to be, and so the people who do urodynamic studies are expert, specialized in voiding dysfunction.
That's a bad I know, because I have enlarged prostate, and my doctor, Dr. Philip, maybe recommended for urodynamic study.
Yeah, common thing to do, yes.
Doctor, it's a Philip, Catalyst.
Oh yeah, go do urodynamics, yes. I don't do urodynamics.
But my point is, gentlemen, see, we are here pensioners, mostly elderly people. And a pensioner gets a limited amount of pension. And this test will cost $800. Where from you will pay?
Well, you can have a lot of these things at the public hospital as well. You just need to go to to a urologist who can refer you to the public hospital.
But in most of the public, there is no urologist.
No, you can see people in the office and then get sent to the public hospital for your urodynamic test or anything. But yes, I mean, the only public hospital urology clinics, Concord has one, Westmead has one, Prince of Wales, so there are North Shore, so there are public hospital urology clinics
I
around.
bet you Hornsby, there is no there.
Yeah, I doubt there is one there, but there are plenty of
I'm
clinics
supposed
around.
to ask I need clarification.
Yeah, so if anyone wants to be seen in a public hospital, then there are a handful of public hospital clinics around. The only problem is that the wait is significant to be seen in a public hospital clinic, and also for any procedures, the wait is significant. So if you have a urodynamic in the private system, you would probably have it in 2 weeks' time. If you have a urodynamic in the public system, I don't even know what the wait time is.
Okay, thank you very much.
All right, shall I move on? Okay.
A round of applause, please, everyone. Arya Nagar. Ladies and gentlemen, Dr. Arya Nagar. Now, a lot of people just call me Wayne because as a person with a funny last name myself, I know what it means, so I apologise and I empathise at the same time. So it's a unique one. I've actually currently got something close to home with regards to what we just heard, ladies and gentlemen. My uncle at the moment is currently experiencing this and battling this, and a lot of the stats that we just heard about ring really true. The screening, the dealing with things early enough, and having a really good support network around is really important as well. So for anyone either going through it or knows someone who's going through it, there are lots of resources out there and a lot of incredible people here to nitpick, in terms of pick their brain and get some information if you need some. So thank you again, Doctor, appreciate it. Before we move on, ladies and gentlemen, this event is in fact supported by the City of Ryde, and we have some some wonderful members, some wonderful councillors here as well. So I'd like to take a moment to just allude to them, and we'll get a short little speech here. And we're lucky enough to have the mayor here. So first of all, a round of applause for Sarkis Yedelian, the mayor of Ryde. I'm not going to lie, to do a quick Google search on Sarkis. I'm not from the city of Ryde, unfortunately. I believe it's a wonderful city to be a part of, but I've just got here, for those of you who don't know, Councillor Yedelian, am I saying that right? Correct, 1 out of 2 ain't bad. Has been elected as the new City of Ryde mayor following an extraordinary council meeting held on 13 December. When was that? What year was that? Last year. He's a central ward councillor and was first elected to the City of Ryde Council in 2000 and, anyone? 2004, is that right? 4. Someone to my left, you win. Incredibly, he's currently the longest serving councillor. He's served as deputy mayor 3 times, and in 2009 was awarded an Order of Australia Medal for his services to the community. So yes, a round of applause, and Sarkis, if you don't mind, a few words, please. Thank you.
Hello everyone. By now you gathered that I have a strong English accent, although I've lived in Australia the last 45 years. English was my last language, the 5th language actually. I was the first non-speaking background councillor to get elected on the council. Before me, all the councillors were Anglo-Saxon or born in Australia. I wasn't born in Australia. Came in when I was 24. So I'm a president of Ryde Multicultural Centre. There is a centre in West Ryde here. We have mainly seniors gathering there every day. We discuss all those things, cancer and other related issues, senior-related issues there. I acknowledge my fellow councillors, Deputy Mayor Shweta Deshpande, just entered, and Trenton Brown. Look, cancer is something runs in every family. Unfortunately, everyone is touched by someone in the family. My own family, my grandmother passed away with cancer, my auntie just recently passed away from cancer. And although we discussed about ball screening, and multicultural people are a bit reluctant to do that, I did it 4 times, and it's good that government has this procedure. They send an envelope, and like we heard it earlier, and you can do it in the comfort of your home. So I encourage everyone, especially seniors, like we mentioned by our expert, to have any test. Sooner you know that you have something wrong with you, sooner you can fix it. Longer you live it, more problem for yourself, and more importantly to the loved ones, maybe they will suffer because of it. The City of Ryde is proud to support Aasha, and they were a great organization. They lighten their communities, a lot of information, and very happy that today they put on great panel together, and we are discussing it openly. I'm sure this discussion will follow in your families and make sure that everybody knows about it. Believe me, Australia is the best country. I came from Lebanon during the Civil War. My parents came there as a refugee from Armenian genocide. So I speak Arabic, Armenian. I did my education in French. I had to learn English last 2 years in high school to go to American university. I speak Turkish. So unfortunately, it's too late for me to learn any other languages now. Because you are young, you learn. It's easy to learn. And necessity is the mother of, as they say, the whole invention. You need it, you learn it. Congratulations to the organizer. Thank you to the panel for your very wise professional advice. Please don't hesitate. You need anything, multicultural issues, any issue related to your everyday life, approach the council. Anything medical, don't bring us, bring your expert. Thank you very much.
That's a great way to finish off, I think. Another round of applause for the Mayor of Sydney. I heard someone in the audience say it's never too late to learn. Who was that? Never too late to learn a new language. Is that right? Yeah. Someone said that. Someone said that was you that said that. How many languages do you know? 4. That's impressive. Anyone here know more than 5 languages? Seconds probably.
Struggling for
That's incredible. We've actually got.
I didn't write 5, I speak 6.
What's the 6th one?
The Greek.
Great,
I
wonderful.
live in Cyprus.
All right, very quickly, I might move on. We've got also the Deputy Mayor here, Shweta Deshpande. We've also had Councillor Bernard Purcell, we've Councillor Trenton Brown as well. Other round of applause, absolutely right. And after all of this serious talk, we thought we know exactly what you guys think. We need a little bit of entertainment. You might have heard the jingle jangle of some beautifully dressed women who are about to perform and about to entertain you all. Let me give you a little brief about Nadia from the Nadia Dance School. So Nadia's been dancing for over 20 years and has a degree in dance from the University of New South Wales. She's got extensive experience in teaching and performing in a variety of styles such as Latin dance, Bollywood, and of course belly dance. I can see a lot of your eyes already drifting over to Nadia, but stick with me for at least 30 seconds. Today she will be performing 1 Bollywood solo and 2 duets with one of her best students, Alessandra. One of the duets will be a belly dance, and the second a fusion of belly dance and Bollywood. Are you ready to see this? Yes, we are. Nadia, Alessandra, take it away and enjoy. But enough from me. Back to them. They've got one more to go. Here we go.
Like 2 minute break.
I think they want you to go for longer. So
No, there will be an audience participation after this last one. So
We need to steal ourselves.
So you need to get ready.
get excited.
come up and join us on the dance floor. And we're gonna do a bit of Bollywood.
Don't be afraid, ladies and gentlemen. I saw a couple of you dancing in your seats there.
Alright, ladies? Yes, come on up. Woohoo! Come on up, any one of you? Gentlemen? Gentlemen? Come on up. Yay, we got our first volunteer. Gentlemen?
I think I saw Sarkis put his hand up.
Anyone? Yes? Would you like to come up? Yes, come on up. Excellent. Alright, spread it out here. I'll show you what to do. Very simple. Yeah.
But wait, one of you men is coming up, one of you men has to come up.
Ladies, I know this lady is very good dancer. Come on up. Yeah. I promise you it's very easy. Very easy. Come on up. See everyone, we have a dance here. Anyone here? Alright everyone, so I'll just show you a few very simple moves. I'll make up more as we go. You just have to follow me. Okay, so the first one is wipers up and down and up and down and up and down. Now we're gonna twist to the left and twist to the right. 1, 2, 1, 2, 1, 2, 1, 2. Now a little hip drop, right hip. Hold your right hip, and we're gonna go 1, 2, 3, 4. Yeah, drop that hip. And left hip. 3, 4, 5, 6, 7, 8. Now shoulders. Right, left. We're gonna go forward and back. Shake those shoulders forward and back. Now, there's a move in the second song that I'm going to show that might be a little bit, confusing, so I'll just show it to you in advance. We're going to go bounce, 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 flick, flick, bounce, 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 flick, flick, bounce, 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 flick, flick, bounce, 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 flick, flick. And at the end, there's a song that you might recognize once you hear it, but the movement to that is we're going to go palm down, palm up, palm down, clap. We're going to do that 5 times, so let's do it now. 1, 2, 3, clap. 1, 2, 3, clap. Third time, clap. Fourth time, clap. 1, 2, 3, clap. And we go up and down and up and down and up and down and up and down. I'll give you a signal when that's coming up. All right, so can we play now before we
Oh, that was some exercise. Thank you, Nadia. Wait is here. Have your breath.
All right, ladies and gentlemen, have we caught our breakfast yet? I can see Jordan Lane over there. Jordan, welcome. Jordan, have you caught your breath yet? Yeah, good. You happy? Did you want to say a few words? You're all right. Come on up. Well, let's welcome Jordan Lane, ladies and gentlemen.
Yeah, no, that's good. I have caught my breath. I wasn't expecting to walk in and do a dance. Welcome to Ride, everybody. For those of you that don't know me, I'm Jordan Lane. I'm the State MP for this wonderful community. And thank you for being here and for celebrating, of course, culture and tradition, but also raising awareness for the very important cause that is cancer and that affects communities non-discriminatory. It affects people whether you're rich, poor, no matter where you're from, what you believe, who you love. And so I think it's really great that we spread that word, particularly in our cultural groups. I know the mayor was here before. I think he says the department deputy mayor, Councillor Shweta Deshpande is here, great advocate, not just for our Ride Indian community, but Ride more broadly. Councillor Trenton Brown at the back as well. I think that this is a testament to the great thing that you're doing here, that you get so many councillors and, of course, elected representatives around to support these great causes. So, to your wonderful leader, where is she? Thank you for everything that you're doing. Yeah, we should give her a clap. A very long-standing community activist bringing people together around important causes, and this is no exception. So thank you for what you do. Thank you for having me. I look forward to getting around and speaking with you all. Thank you.
Jordan has just segued perfectly into what our next segment will be, which is introducing the wonderful lady that is Virginia and the lady who leads this wonderful foundation, Aasha. When I first heard about Aasha, when Virginia sort of put her arm around me in a very maternal way and said that you are now family. And I think that's really the crux of what Aasha is all about. It's about making sure that the people who are sometimes forgotten and often forgotten, our elderly, our senior citizens, we've all got parents, and my parents are of a similar sort of age group. It's about them deserving the best, about leading a great mental, physical and emotional life. So without further ado, firstly, thank you, Virginia. I'm sure you'll all join me in thanking her. Thank you, Virginia, for putting this on, for having us here, and let's hear from the lady herself. A round of applause for Virginia, ladies and gentlemen.
This is just a little snake of what Aasha does. So it's a little video with some of the activities that we do. I don't believe in saying thank you. Then you are very kind. Thank you to everyone. Can we have that?
And keep on dreaming, or you can get up and make your dreams come true. So Aasha is one of those dreams that some of us decided that we need to wake up and make it happen. Now Aasha is all about hope. Hope for the people, hope for our seniors, hope to have a happy life, hope to have a place where they can meet people, they can sing, they can dance, they can be respected, where they feel they are cared for, they are sporting, and where they feel they can be themselves. Everybody has a right to be happy. It doesn't, you may be old or young. A lot of times we people forget, and we look at old people with the wrinkles, but they forget. They may have wrinkles, but they have a heart that looks for happiness, a heart that wants to be loved, a heart that wants to be cared, and a heart that wants to be with people of their own culture. They want to share the food that they have tasted when they were growing up. The music they heard when they were small and when they were growing up. Although they have come to Australia and my nation has got a lot of problems, and often our isolated. Children go to work, grandchildren are busy playing with their computer games. Their daughter-in-laws or daughters are too busy doing the housework or chit-chatting on the social media. But what happens to those seniors who left their home, their friends, their homeland to give a good start with their family? And often those people are lonely, isolated, and depressed, and often unhappy. So Aasha and the Aasha team was started to give that hope to those seniors. And the way we do it is by having 5 seniors groups, and we hope that we'll have many more groups so that our seniors can choose where they want to go and with whom they want to spend their day. We do the health checks. By this time, thanks to our team of doctors who voluntarily have done more than 1,000 health checks. We do it in our social hubs, we do it on the community events. We have been able to produce resources for our community. With senior rights, 2 short films in Hindi have been produced, which are on the website of the senior rights. We have produced a short film on dementia, which was done by Nani and in Victoria. And this is also on the website, which is creating awareness for the people how to cope and identify dementia. We have been able to produce a DVD along with Dementia Australia of the stories of the real people who have dementia and their carers. We have tried to lobby to the government and inform them that they have care, we have culture, and that our people need to have culturally appropriate care. So we have done that, but we need to do much more, and this is only possible if community and all of you come along, and together we can make this place a supportive community where you can be happy that your families, your seniors are happy. And don't forget, all of us get old. When I was growing up, I thought grandma was born old, but as time goes on, we realize that time comes, we all get old and we are scared. What are we scared of? Scared of being lonely, scared of being helpless because our health is declining, and we are scared of losing the control. We are scared of that nobody will care for us. And even I am scared of that. I don't want to be stuck in a nursing home with the deodorant and with the Dettol smells around me, with the food that I don't enjoy, with the music I don't connect with the people who don't understand my language. So all I want to have is a place in Australia and give that happiness to our seniors where we can choose to live they want to live. So please support us, become our neighbors, become our volunteers, sponsor us, give your donations, and come together and help us to take it further so that this adopted land becomes a home for all of us.
And that's what Aasha is. That's what we do. Aasha is hope, and this says it all. And I do like to acknowledge the elders of the land and the elders from all over the place who have come and made this place home. We are grateful to City of Right for sponsoring this event with the funding. It may be little, so if you give us more, we can do bigger and better things. Simple as that. And I'm very grateful to a lot of people. Running an event like this doesn't matter, there will be 10 people, 20 people, it's a lot of work. A lot of people behind. First of all, I'd like to thank all our speakers, all our panelists. Just one phone call and they're here. And all our VIPs, I know they're busy, lives are very busy, and thank you very much, each and every one of them. I don't think I should name them, they are in front of us, we appreciate, and we do hope that you will continue to support us, give us encouragement, give us strength, so we can do more things for you. The more you support us, the better we can do things for us. I'd like to acknowledge Harmon Wali also, who is our media partner, and Harinder Singh, who runs a Facebook, YouTube channel. Thank you for supporting us, always being for us. There are few people, I'm going to invite my other two directors, Dr. Sundar and Dr. Raju as well. Let's give them a big clap. Thank you for having trust in me, and thank you for supporting and standing with me forever. Special, all the Aasha team members are there. I like to mention special thanks to Salia, who has come all the way back, returned from his holiday from Sri Lanka to 1 o'clock in the night to make the certificates and run this event. And to Wayne, what can I say? I saw him in the Olympic Park when Modi ji came talking to 25,000 people, and I said, I'm going to get him. And he said to me, how did you find us? I said, nothing is impossible. And same, the look at the panel, and I like to acknowledge our Commissioner, Dr. Robert Fitzer. Thank you so much. I know you are very busy, and we really appreciate it. And Michelle Bell from KNC, and thanks to Michelle also, we are going to start a group in Gordon. And you have just seen little what Nadia does. It will be exercise, it will be multicultural group, so that with yoga and with Bollywood music, we can reduce cancer, we can reduce mental stress and do a lot of moves. I was on the Monday at the launch of the Multicultural Health Week. Sheetal is there from New South for Multicultural. And the theme was, every move counts. And that's what we do. So if anybody who does the multicultural should be supporting and giving money, should be us, because we are doing it all the time. I like to acknowledge all the people who are sitting in the front for registration, Jinder, Tanu, and the people behind in the kitchen also, who will be serving you the refreshment, Sam and Jagdish. Sudarshan, I call him Sam. That's a nice weather. And to Rajesh and all other people who support us. And thank you for all of you who are here. We don't need anything. And all the councillors from City of Rai and all the people. So please help us. We just like to say a little thank you with the certificates for the people. So Sonali is there? Yeah. Sonali, you want to? Christopher Monson, Dr. Reddy. And then one of the, you can give them this. So this is just to say thank you from us. Appreciation. Dr. Mohan. Give us something. And next one is Dr. Mohan. Michelle, thank you. Michelle gave us encouragement to start our new group on 9th of October in the Gordon Library. This is the opening of the Gordon Multicultural Group. Another one, the 6th one. Thank you. Padme. Now Padme is advocate for Pigside. And thank you, Padme. She's a cancer survivor as well as the advocate for Pigside. Thank you, Padme, for coming. She'll be my advocate. What can say about Palu and Aviji? I can say thank you for being friends and thank you for supporting. Palu is a good friend and she's a cancer survivor and she has done a lot of work inside. And we acknowledge Aviji also apart from his supporting. They're raising funds for cancer. So thank you, Palu, for coming today. And this one. And Hetika. Hetika does a lot of psychology work and she supports the mental health of the carers of the cancer and a lot of mental health. Thank you, Hetika. We look forward to having you with us. I must say today is just the beginning of this series of the workshop we'll be doing. This is the forum. We'll have in our groups invite experts to talk on different concerns and different sort of more information will come out. And Robert is the Commissioner for Disability and Aging Care. Very busy, very important person. Thank you, Robert, for coming and thank you for us. We look forward to being a part of Robert Disability. Wayne. What can we do without Wayne? He's such a charming person. He's one of the best MC you can ever have. Dr. Sundar, can you pass? When Diwali coming, we're giving you the lanterns for Diwali so that you can celebrate
That would be
Diwali.
very good for my wife, I think, I'm sure. So thank you very much.
And to Salia, who's got Golden Water Multicultural Events Organization, Sri Lankan, who have become our partners, and all the work Salia is doing. Thank you. Send this man. Salia is our production director. He has done big events like for the Bollywood production for 35,000 people in Sri Lanka. And we are very blessed. He was only at 1 o'clock making these certificates. Only at 1 o'clock in the night. When he sent me, I said, oh my God, this fellow is still awake. Thank you, thank you. So with this one. So Raghav, the catering is done by them, and thank you. So I'll give to Wayne and we'll start up and up. Thank you. Did I miss somebody? Have I missed somebody, please?
Thank you, everyone, and thank you, Bajinga. Please join me in thanking Bajinga Dugal. A few of you will be wondering, we haven't really been introduced, or we haven't really heard from some of our distinguished panel here as yet, and this is the part 2 of this wonderful day today. So, without further ado, let me introduce a couple of very important people here. We have, just immediately to my right, Robert Fitzgerald, who is the current Commissioner of the New South Wales Ageing and Disability Commission. Mr. Fitzgerald, who is a lawyer by profession, is that right? It is. Do you tell many people that? No? Okay. Don't tell anyone else that. He's a lawyer by profession, and the Australian government actually appointed Robert as a Commissioner on the Royal Commission into Institutional Responses to Child Sex Abuse from 2013 to 2017. Robert was also appointed to the chair the Australian Charities and Not-for-Profit Commission and Advisory Board for 3 years from 2012. And most importantly, Mr. Fitzgerald was a convener of the Indigenous Disadvantage Working Group of the Steering Committee for the Review of Government Service Provisions for over 9 years. Please join me in making a warm welcome for Robert Fitzgerald. Thank you. Next up to his right, we have the wonderful Michelle Bell. Michelle Bell is the CEO of the non-for-profit charity Kurungai Neighbourhood Centre. Care, whose mission is to keep people connected within the community and living independently. 2 reasons why we're all here today, am I right? Yes. Each year, KNC assists more than 135,000 individuals with connections to activities or programs to assist social inclusion. With a background in health as a physio, if anyone was wondering. She's got extensive experience in the social sector. Michelle has considerable experience in the social and health impact value of social connection. KNC's mission is to be leaders in information, builders of well-being, and partners in social connection and inclusion for all. Michelle and KNC are focused in their desire to develop health communities, wellness and social connectedness. Ladies and gentlemen, a warm round of applause for Michelle Bell. Next couple of people were people that didn't give a lot when I did ask, what would you like me to say about you? They're quite modest people here. Not that the first, I mean, they're all distinguished. Now I'm digging myself a hole, so I'll quickly put the shovel down and just continue introducing Hitika Bhatia, who's a clinical psychotherapist providing psychotherapy which emphasises the integration of different aspects of the self. This approach is beneficial if you are seeking to explore how your past experiences impact your current relationships. This can lead to improved communication and strong connection with self and others. And by exploring unconscious thoughts and emotions, people may find new sources of inspiration and creativity. Something I think I'll be talking to Hitika about later on. So welcome, ladies and gentlemen. Hitika Bhatia, please. Thank you. To Hitika's right, we've got Dr. Palu Malwa. Hello, Dr. Palu, how are you? A GP, for the best part of 20 years, she's been a solo GP. Her practice is out Parramatta Way, if anyone was wondering. We heard earlier, Virginia said that she's a cancer survivor, a breast cancer survivor, which is incredible. She's also the ex-president of the Australian Indian Medical Graduates Association. Did I get that right? Yes. There's a lot to remember, but ladies and gentlemen, please welcome Dr. Palu. And last but certainly not least, we have Padmini Peris, a Pink Sari Advisory Board member, patient advocate, and also a cancer survivor. Padmini is a cancer survivor who has worked tirelessly to ensure successful cancer outcomes for people from the Indian subcontinent, particularly those from a Sri Lankan background. Padmini earlier told me that she had cancer and survived cancer 6 times. Is that right, Padmini? Incredible, incredible. That got me quite a lot, actually. Padmini is a driving force behind breaking down cultural taboos about cancer and encouraging more women to have breast screening mammograms within their community. She loves nature, she's a motivational speaker, but she loves spending most of the time tending to her family garden, which we may or may not hear about later on, who knows. But ladies and gentlemen, please welcome Padmini Peris. I'm now going to pass on the microphone and let's keep our attention and our respect to Robert Fitzgerald. Thank you, Robert.
Oh, good day. I must say it's a great joy to be here, and a couple of reasons why it's a special joy. Firstly, I haven't walked down the road, only having been, this is the first occasion that I've had as Commissioner to actually walk anywhere on any event, so thanks for that. The second thing is I must say that the entertainment took me back to India where I was only a couple of months ago. In a very different role, I chair an international development agency, and I was visiting development programs and humanitarian programs throughout India, and I was certainly taken back with the dancing today and the entertainment, so thank you for that. But the third thing, and the real reason I'm so excited, is because of the slogan that sits under Aasha's heading, and it says simply, caring for those who cared for us. And so you're going to say, why is the Ageing Disability Commissioner here on a day talking about cancer? So let me just give you a little bit of a background. The Ageing Disability Commission was established by the New South Wales Parliament just 4 years ago. And the reason was very simple, that all of us were becoming aware of abuse of older people in our society and abuse of people with disability. And I'm sure those on the panel were aware of that. But what would you do about that? What would you do if you saw somebody like myself, a senior's, actually being abused? whether that's emotional, psychological abuse, or financial abuse, or being neglected, or suffering physical or sexual or other abuse. And so what the government did of the day, supported by the whole Parliament, was to say we need an agency that can actually prevent and respond to that level of abuse in our community in New South Wales. And just a couple of things about that. 190,000 older people in New South Wales identified as having been abused in the last 12 months. It's a lot of people, isn't it? 1 in 6. And I bet you it's 1 in 6 in the Indian community as well as the Chinese or Arab people, any of the communities we deal with. So this is a big problem. But I'd also bet that in the Indian community, very few people talk about it. In fact, all you'll talk about is how we value our older people. And yet you and I know that's not absolutely the case. So our commission is about preventing and responding to the abuse of older people and people with disabilities. And everybody that's over the age of 65 in New South Wales is in my jurisdiction, which is a lot. So we run a helpline where we take 14,000 calls a year for people that just want to raise concerns or make reports about that. We have a lot of staff that work with families, try to work out better arrangements. And often abuse is where relationships have gone very bad. And the really interesting part of this is that the areas we concentrate on is abuse within the family. And two-thirds of that are by sons and daughters of older people. And that's a really shocking thing, isn't it? And that's true in all the communities. So about two-thirds of all the matters we deal with for older people that are allegedly abused, it's by sons and daughters in their own homes and in their own families. And so every community I talk to, this is a challenging thing. It's challenging because it's a bit shameful to think about it, isn't it? And nevertheless, shame can't be a reason why we would allow someone to be abused. Shame can't be a reason why we wouldn't come forward. But if you think about it in terms of today, where do we see the greatest risk? It's for people in their mid-70s to mid-80s. Just think about yourself. If you were about 75 and you got a diagnosis of cancer, and at the same time you started to be, in fact, the signs of dementia were occurring. In fact, you might have a diagnosis of dementia. And that's the group we mainly deal with, 75 to 85-year-olds. How confident would you be that you're safe? That the decisions you want in respect of your life, people would respect? How sure are you that your sons and daughters, your spouses, the carers, will actually listen to you as you get older? Listen to what you want. Listen to the needs that you have. Well, do you think what they might start to do is take control? You think they might start to say, well, we know best, you know, you're getting old, you're sick. And the three things that happen to us when we get to about 75 years of age is we become frailer, we become more dependent on other people, and some of us, not all of us, will start to lose a little bit of our mental capacity. And that is the big risk for older people. So in your community, in every community we deal with, here in Rye or anywhere else, the same issues is how are we going to make sure that you feel safe and you are safe? And if you're not safe and there's abuse, how will you come to an agency like ourselves to work with that? And finally, we work with all the organisations that you can think of. We work very closely with hospitals. Why would we work with hospitals? Because when patients that are older are being discharged, there's meant to be a discharge plan. And at that point, many older people, including many older people from the subcontinent and from Southeast Asia, all over, start to reveal things that are happening in their life. And of course, no one's meant to be returned home unless it's safe. We talk to the police because some of the matters we're dealing with are in fact matters that are going to lead to criminal charges, particularly financial abuse, which is very common. We deal with all of the community service organisations because trying to make you safe is also about making sure you've got the right services. And in multicultural communities, what we find is often one person in the family is taking the primary care responsibility. And everyone in the family says, oh, we support him or her. Well, we find that's not true. That they've got a lot of opinions about him or her. They tell the eldest daughters what she should be doing, but do they actually support her? So we work with home care and other groups as well to make sure it's well supported. So the connection here is this. Older people need to be safe. The only way that's going to happen is if each of us work together to try to create safe environments in the home, in aged care, in our institutions, working at a local level, working with community organisations like Aasha, working with professional people. But when you get health and mental decline coming together, then the risks grow. So that's what we're about, and this, we'll talk a little bit further about that. So that's the Ageing Disability Commission, and you should never believe anybody that says we're from the government and we're here to help you. That's a very bad thing. But I've got to say the commission is from the government, and we are here to help you.
I think he stole my speech. Thank you for having me here today. Our organisation is Cancer Care. We started as Coringa Medical Centre, but because of the diversity that we had in the region where we were in Coringa, we listened to our community and we had to expand. I have to tell you the most terrifying thing I've ever had to do was take services from Coringa into Hornsby when the two areas did not want to merge or they wanted to merge. So we became a service that was more about community and neighbours and people. And Cancer Cares is about an organisation that now works throughout most of New South Wales and down the eastern seaboard. We are very, very busy in this region for many of the reasons Mr. Fitzgerald has just spoken about, doing home and community care and disability. For us, health is everything. To age well, you need your health. And to age well, we have to try and encourage our community. And I'm not being sexist, but we need to encourage men to worry about their physical health and their mental health. And you have to be prepared to stand up and be strong. Think about things the way women do, whether it's skin cancer or we go have our breast cancer screenings. Men are reluctant, and by the time they often get services, it's too late. So we spend a lot of time, particularly in the western suburbs, Parramatta, everywhere, encouraging people to think that it's a natural part of life to just be screened, and an early result is a positive, even if it's a negative, because it can be dealt with. For us, early intervention with cancer screening and cancer prevention or dementia means for a healthy older life. And a healthy aging means a healthy community. I can't stress more strongly the amount of time we spend with abuse. Emotional, physical abuse, particularly children and particularly families. And that comes often from stress, cost of living stress, health stress. So I urge everybody to just think about it, particularly in the communities that we're working with, and in your own communities, to also think about your own unconscious bias. It's not just the borders who have to do the care. It's not just the men who get to make the decisions. If someone is ill, if someone has dementia, broad your thoughts, okay, how do we, as a family, can deal with this? How we use services, and there are so many services you can use. So first and foremost, in aged care, my aged care, the one thing the government's do, I know I have a lot of arguments with government at the moment about how they handle aged care and disability, but my aged care program does work. And you can register at 65, or if you're Aboriginal, over 55, you can be registered to receive so many services at minimum cost, whether it be community services or home care services. However, we're also aware a lot of people don't know how to do that. The federal government has now sponsored a program, particularly in Sydney North, but we've extended it to western suburbs and Rye. It's called the PACE program. If you're diagnosed with a recent diagnosis and you don't know how to handle it, you feel lost, your family feels lost, your father won't get help, and but also very worried. This is a free service to and duty service. And it can be done, and it also allows you to be socially connected. So I guess my statement today is be aware, care for yourselves, care for each other, but most of all, get screened and gain information. If you haven't got information, come to people like providers who can tell you where you can get the information that you need. And if you know anyone who is registered, please, our hotline, we have information's number on our hotline.
Thank you. I think those were really important points raised. Thank you to Aasha Foundation who's organized this, and Jinder who she does great work. You've got such a beautiful reputation, and the amount of work you do is commendable. Thank you for having me here. So I am Hitika. I am the director and clinical psychotherapist at Blossoming Minds Therapy. We're based in Auburn Hills, the Hills Private Hospital, part of Health School. I wanted to, I think I'll actually do my part in 2 languages. I'll start with Hindi first. How many people here speak Hindi? Can I have a raise of hand? Thank you. नमस्कार, मैं पहले हिंदी में इसलिए बोलना चाहती हूँ कि आप तक जो भी ये पॉइंट्स रेज हुए हैं वो पहुँच पाए, वो आप समझ पाए। कैंसर एक बहुत डरावना सा वर्ड है, बड़ा ही स्केरी सा शब्द है ये, लेकिन इससे डरना नहीं है। तो मेंटल हेल्थ एक बहुत बड़ा पार्ट है जो कार्ड कम्युनिटीज़ या हमारी इंडियन कम्युनिटी में, साउथ एशियन बैकग्राउंड्स में ये चीज़ बहुत डरावनी सुनाई देती है। कैंसर सुन के सब लोगों को थोड़ा डर लगता है, लेकिन ये बहुत ज़्यादा डरावना नहीं है। जैसे कि डॉक्टर मोहन ने यहाँ पे पहले बताया कि स्क्रीनिंग पहले कर लें आप। अगर आप ध्यान रखेंगे अपने जो आसपास रहते हैं, अपने लव्ड वंस का थोड़ा ध्यान रखेंगे, अपने चेकअप्स पूरे कराएंगे, जीपी के पास जाएंगे, अपनी स्क्रीनिंग कराएंगे, जैसे कि क्रिस ने कहा अपनी स्क्रीनिंग किट को ढंग से इस्तेमाल करेंगे, तो इसके लिए ज़्यादा बड़े साइड इफ़ेक्ट्स नहीं होंगे, उतना डरावना नहीं लगेगा ये। उससे पहले सेल्फ अवेयरनेस, अपने आप को, अपने रूटीन को, अपने लाइफस्टाइल को ध्यान में रखना बहुत ज़रूरी है। और ये ध्यान में रखना ज़रूरी है कि हम अपना कितना ध्यान रखते हैं और हम कितनी इनपुट देते हैं अपनी फैमिली में इस चीज़ के लिए। हम बहुत बार इस शब्द के साथ इतना डर जाते हैं, जैसे कि मिशेल ने कहा कि मेंटल हेल्थ बहुत इम्पोर्टेंट है, कि शायद जो हमारे घर के बड़े हैं वो प्रोवाइड करने में, सबका ध्यान रखने में, बीइंग द प्रोवाइडर ऑफ द फैमिली, सब लोग इतना उसमें इन्वेस्ट हो जाते हैं कि शायद उनको जानना ही नहीं कि हमें कुछ है। इसलिए शायद ये आसान हो लास्ट मिनट तक स्क्रीनिंग छोड़ देना, क्योंकि इस चीज़ के साथ रहना कितना बड़ा इम्पैक्ट है हमारे मानसिक संतुलन पे। तो प्रिवेंशन सबसे पहले बड़ी बात है, क्योंकि शायद हम या घर के बड़े इस चीज़ को इग्नोर तो कर देंगे, लेकिन उसका कितना बड़ा असर हमारे पार्टनर पे, जो हमारी केयर करते हैं, या हमारे परिवार पे पड़ता है, हम उसके साइड इफेक्ट्स कई बार नहीं सोच पाते। सो इट्स रियली इम्पोर्टेंट कि आप पहले इस स्क्रीनिंग को ध्यान में रखें, ताकि अपना मेंटल हेल्थ, अपना मानसिक संतुलन और अपने परिवार वालों का भी बचा सकें। Sorry, I had to speak in Hindi for a little bit because I thought that it was such an important message that goes across to each and every person sitting here. English is definitely a language that most of you understand, but I wanted to make sure that it is understood by everybody here whose second language is English, or in some cases 5th or 6th. So prevention in mental health is really something I wanted to focus on from a cancer lens, from 2 parts. The first part is the one who are living and who have been diagnosed or have fought cancer. The mental health impact that they've had is something that I don't think we can measure, but also the impact of who have cared for them, who have lived with them, who've lived in the fear of what may happen to them, and I think that takes a massive toll on their the family and the person who is going through all these tests, all the screening, everything that happens. So it's important that my emphasis would only be, as Robert said, it's the safety, but I guess take that a step further to talk about mental safety. If we're not comfortable facing this and accepting that within ourselves, especially for the elders in our house, in our families, I think we would be ignoring a very big chunk of population. And eventually it comes back, the mental health comes back, because if someone in the family is suffering, we all would be suffering with it. The second thing that Michelle said was very important as well, men's mental health. It is a massive area that isn't ignored, and I think a part of it is by men. You don't have to be fighters all the time. It's okay to put yourself first and your care first as well, especially because, like it was put forward in the talk by President Dr. that 14% is just bad cancer in the Indian community. So I can't imagine how big is that number if all other cancers were put in that as well. I can imagine that would be a massive number. I've had, it's quite personal to me as well. I've lost my grandfather to cancer, and I wish you knew earlier. Had we screened earlier, had we known earlier, I guess the cascade of what happened might have been different. Not to mention that the grief and that loss lingers in many parts of depression for decades in the family and how it's impacted. So it's really important that we understand that it's not scary if you screen it earlier, because the person who leaves, who passes, is not, they're definitely impacted, but who are left behind are also severely impacted. So I wanted to emphasize on that and the severity of mental health in the process as well. Thank you for having me.
Hello everybody, I'm Palu Malawala. I'm a general practitioner who practices in the Hyderabad Parramatta area, which is, I've got a very Indian dominated practice. I do have all others as well, but about 30% of my patients are all Indians, of Indian origin I mean. And I just want to tell you that I'm the one who actually tells my patients, look, you have to lose weight. See, this is the way you deal with diabetes. This is the way you have to cancer screen. We do the PSAs for people. We actually show people how to do the breast check. We do the pap smears. We are there to do these things. And I was shocked that 10 or 12 years ago, I went for a routine breast screen and nothing. There was no lump, there was nothing there. I was very active. I used to go to the gym 8 hours a week. Nothing could go wrong with me. I'm the one who's advising people, And suddenly it came up, please come back, we need to rescreen you because there's some problem. And I thought, 20% of people get rescreened, no problems. I went back, and then they told me, look, something looks suspicious, and we should have a core biopsy, which we did. Then suddenly it was, the results came back, yes, it is cancer. Then we had all these battery of people. I had the social worker, I had the surgeon, I had the psychologist, everybody there. It's a team, it's a beautiful team that comes together and tells you, and is there supporting you. But, and Abhijit, my husband, wasn't me. I just started crying. And, I didn't know what to do. I mean, I'm the person who's not wonderful. I'm the person who actually gives support to everybody. How could this happen to me? Okay, so I had the support. was that he would be here with you. And guess what? I got off very hard. I had the surgery. It was, it was not, I didn't get radiotherapy, I didn't get chemotherapy. I just thought it was nice. And even after 12 years, when I think of that time, I'm worried. I am worried. So what I'm saying is my experience. I'm not saying anyone else's experience. Please, it can happen to the best of us. We exercise, there's no family mechanism, history, whatever you think. It's the most risk factor is that you are a woman. Of course, it happens in men as well. But the risk factor is that you're a woman of any age. It can happen. So please be aware and listen to your body. Okay, anywhere. It could be a lump. It could be a bit of bleeding, a bit of tummy ache that doesn't go away. It could be that you can't control your urine. It could be anything. So please get it checked. And today I stand here with ceremonies for you because all the support that I've had, all the support is fantastic in Australia. So please make use of it. Thank you so much.
Hi, thank you for inviting me. My name is Nandini Paris. I'm actually Sri Lankan. My story is slightly different from everybody else's. I have been diagnosed with very early stage of cervical cancer a long time ago, even before I turned 40. That was sort of an accidental one. My GP actually noticed some mosaic appearance on my cervix, and she told me she wanted to get it checked. So the oncologist told me, he agreed, and he said, in his experience, 99.99% it was negative. I could leave it or he could remove it. So I said, no, go ahead and remove it. And it turned out to be SIN1, which is the first stage of cervical cancer. But after that, everything was okay. I completely forgot about it. Year 2000, I was 42 years old. I found it out, and then I was diagnosed with breast cancer. I had no family history, nothing whatsoever. Like Khan said, I was very active, exercising, eating healthy, nothing at all. But at that time, my surgeon thought removing the breast would be more emotionally affecting a person of my age. So he decided to do the lumpectomy and lymph nodes removed. I had to go through chemotherapy, radiation, everything, because cancer has already spread to lymph nodes too. Since then, I got the cancer again on the other breast. At that time, they did the genetic mutation test. Finally now, all my family is negative, but I got BRCA1 positive gene. And I have the most aggressive cancer, which is triple negative BRCA1 positive. And since then, I have had, I can't count, some 6 rounds of cancers and then recurrences, and more than 18 major surgeries. I tell everybody most of my body parts are gone, and I had 4 rounds of chemotherapy, 2 rounds of radiation. But going through all these things, funnily enough, I have never shed a tear. It has never affected me psychologically at all. I'm a senior medical scientist by profession, being a very organized, methodical person. As I'm always, my mind goes to organizing my department, organizing workload, organizing household things, nothing to do with my cancer. I went to hell, basically. During Sydney Olympics, I was even given the last service by the policeman because doctors thought I was going to die because I was that sick. Here I am 23 years later talking to all of you. It's mainly because I have a very strong heart. People who know me know every day I exercise about 2 hours or sometimes more. I work full time and I do everything else, a lot of social work. I think I have no fear of dying. Death can happen to anybody anytime. So the cancer is just a hindrance to my day-to-day work. It's not a hurdle only. I have a choice to be feeling sorry for myself or jump over it, get on with the life. So I have chosen the second option. I want to live life to the fullest till the end. Whatever happens would happen. But in the meantime, I want to help other people with my experiences. Whatever I have gone through, if I can save one more life, I can encourage somebody else to go and get the screening test done, or a person who's going through cancer, if I can support them through some way, that is my mission. If I can help with my experiences to other people, that's all I want to do. I'm very lucky. I'm with this beautiful group of ladies, Pink Sari. We do quite a lot of work to support our patient community, detecting early detection, screening, quite a lot of programs we do. At the moment, with the support of the South Wales Cancer Institute, we do a program called Caring for and Care at 2 different hospitals, Liverpool and Westmead. We have alternative months. We have, with the support of those 2 cancer centers, we do workshops for South Asian people who are detected by cancer. We want to help them to navigate through the health system, support groups, because there are quite a lot of South Asian community people don't like to talk about cancer. There's stigma, there's fear, there are quite a lot of issues. So we want them to feel safe to talk to us, to share their experiences, and then where we could get help for them. We had already had 2 sessions. It's one session, one of the ladies said she's been sent to a nutritionist. They've been given the calorie control diet, but she said, I don't want a Western diet. I want to know what the Indian food, how much calories, how much I can eat. So things like that. That's what we, with the Pink Sari team, we're doing quite a lot of work. If you know anybody who wants help, please reach out to us, because we have every month, either at Westmead or Liverpool, we have these workshops. So please tell all the community, your friends, anybody, to attend these sessions. They're free. We are not professionals to help cancer patients, like medical diagnosis or advice, but we will find out information they will need, and we can supply it. So that's my story, and thank you for listening.
I mean, there was a lot to take in there, but before we go on, thank you for your respect, thank you for listening so actively, but also let's put our hands together for everyone who's just spoken. We heard some stories that certainly weren't easy to share. We saw emotion, we saw active engagement, and we saw encouragement to the group of you here that are present with us today, but also to let the people that you know that now's the time. Let someone know to test. Let someone know a little piece of information, a link, a brochure at the back. Pick their brains, get some information. And I only say this because there's a very similar story. My mother is who's been in remission now for 5 years. She had lung cancer. She's now got 1 1/3 lungs left. She's here, which is a great thing. But her GP, very similarly, just spotted her coughing and said, "Hang on a minute, I know you quite well. That cough is a little bit unusual. Why don't you go and get it tested?" My mum, of course, lots of Indian mums are like, "Oh, it's okay, I'll keep going." This lady GP, who was also Indian, very much knew the culture, and said, "Listen, you need to go and get this test. What's the worst that's going to happen?" And that's a really important message, I think, is what's the worst that's going to happen? You get a great test result back, and that's fantastic. So we thank that GP, so much in our thanks and prayers and whatnot. And I guess a similar note was shared here earlier. Here you go, I can see you. Yeah, absolutely. I'll pass the mic. What we're about to enter is a bit of interactive question and answer as well. So I thought I'd share a quick story, and if anyone else out there has a quick story, noting the time, of course, we want to try and wrap things up in the next sort of 10 to 15 minutes. We'll come around, but I'll very quickly pass the microphone over. Thank you.
Thank you. I really won't take long, but I needed to share this story. Once I was working with a specialist, a neurosurgeon, and there was this Indian patient who had come across, and he had come for 2 of his appointments. And I think, as you know, specialist fees are high. So he had come and got his test done and everything, but nothing came out in the test. He was healthy. So he actually stood there arguing with the doctor and the admin team that there's nothing in the test, I want my money back. So it's a good thing that it's a cultural thing that sometimes it's so manifested in us that we need to take the value out. Perhaps it's okay to spend that kind of money and have nothing come out. So just had to share that. And so would encourage that you spend some money so that it comes out that your test results are amazing.
I think a very valuable point in our community, and I mean I could say it because we're part of the crew, but a lot of us are like, how much does it cost? How much time is it going to take? I mean, we've all got either, I look to the younger ones here, we've all got elders, who might say stuff like that, and I look to the experienced around us, and we've all got younger ones who, I'm sure you guys are like, wow, I'm going to spend a lot of money, because a lot of us here are, migrants, am I right? We migrated. How many of us are born here? Oh, that's incredible. Can I, just one more time, how many in front of me are born here? That is incredible. I mean, maybe the youngest among us, yes. And of course, yes sir. But that is an incredible thing. I was expecting a couple of hands here or there, but I'm a migrant. Yeah, absolutely. Christopher, please.
Thanks. Sorry, I'm not a migrant.
That's all right.
Born here, very two of the boys at home go to daycare and they ask all the time, what were their cultural, and every time, I'm like, nothing. And just the plain Hallmark holiday is nothing exciting to declare, unfortunately. But I just wanted to add, I guess, for the 3 screening programs, at least the 3 that we run for Cancer Institute and we run New South Wales Health, just to be really clear, they are all free of cost. Breast, bowel and cervical screening are all free tests. You can go to a breast screening van or a site. You can have your cervical test bulk billed at the GP. You can, your bowel cancer screening test is free, sent in the mail. And as is the follow-up to that as well, if it's done within the public system, there are always public system options as well. So test and a diagnostic follow-up. And actually, for cancer diagnosis as well, in Australia, we have free cancer treatment in the public system. The weight might be slightly higher than what it might be on the private side. Most of my experience as a treating radiation therapist was in public, but I worked for a little bit in private as well. And on the whole, actually, the technology and the advancement of treatment typically is actually higher on the public side. You can pay a little bit more and have a little bit less of a wait time, but that's something I guess is a personal consideration. But just to be really clear, that, and adding on to your point as well, because there are a variety of services and different screening you could have, but at least for those 3 primary screening programs there as well, they are free of charge.
Just with this bowel screening, just wanted to add one more thing. I don't know whether you agree with me, but just even if you get a negative test, listen to your body. Doesn't mean a negative test means absolutely everything is good and from here on you're not going to get bowel cancer, even like for the next 2 years. So if you think that it is negative but you do have other symptoms, please get that checked out. It's very important. A negative bowel screen test does not mean no bowel cancer. Okay, it's just an additive to your own symptoms, so please be careful.
Yeah, it is a really low risk. We know that you're about 99.9% chance of being cleared within 2 years if you get a test. But that doesn't mean there's not other things going on. Really important to talk to your GP, have that relationship with your doctor, make sure they know what's going on and that things get checked up. Really, really important.
You tell me one thing, you have written, you send a kit once in 2 years from 50 to 74. Does it mean that after 74 we are not, not likely to get a bowel cancer? Or
so the bowel cancer screening program, like all the screening programs, is based on the best evidence that we have of both risks and benefits. We know that for people aged 50 to 74, that is the best time to be screening because it's important to screen. But there is lower risk of follow-up diagnostic, which is a colonoscopy. That's typically quite a low-risk procedure, but for people over the age of 74, we know that there can be a high likelihood of complications. And so that higher likelihood of complications needs to be balanced against the benefits of screening. And the evidence-based decision has been that after 74, it's not ideal to do that as a population screening level. However, it is really important that you talk to your GP about whether or not screening is right for you. If you're 75 or 80, screening might still be a good idea, and your GP can still can have that conversation with you. You can buy kits yourself, or actually your GP can write you a referral. You can pick one up in the pharmacy and claim back the therapy cost on it. So it's quite still a low cost endeavour to do screening, but after 74, it is a conversation you need to have with your doctor, rather than the government just still sending them out to everybody on mass.
I have one more question to the doctor, urologist, Dr. Yeah. You know, I happen to be a prostate cancer survivor. So my question is, after follow-up, do we go to the urologist or the oncologist?
You go to the GP. So it depends.
No, I'm not here. I'm talking in India. I got it done in India.
Well, I can only talk about what happens here, which is after the treatment, you get your blood tests checked to monitor the PSA testing. Initially, I will do it, or if you have surgery, or if you have radiation therapy, radiation for it instead, the radiation oncologist will monitor it. And then after a certain period of time, we refer the patient back to their GP for ongoing surveillance. I always write a letter saying please do A, B, and C, and if this happens or this happens or this happens, then please get them to come back and see me. So everyone who has any cancer will need lifetime follow-up, and with each of these things it's based on the evidence, as Chris said. And the other point as well is that when we stop testing, people also will change depending upon the individual's health. So not all 75-year-olds or 74-year-olds are the same. Some of them are puffing, walking from the waiting room into my office. Others of them complain my knee hurt because I ran city to surf last week. So you've got to titrate what we do to the individual's life expectancy rather than their age.
Thank you. Thank you very much for the question and for the responses. Something that I actually, if there are any other questions at the moment, just pop your hand up and I'll come around to you just so we can all hear. But pop your hand up now and then I'll come around to you. Something that was a great takeaway was what Ithika said about, well, maybe I've got this wrong, but one of you said it about the fact that death doesn't really affect the person who's died, does it? Death affects everyone around. So if there's anyone out there that's here currently, or someone out there, family or friends who doesn't want to take that next step in terms of testing or just going to their GP, you as their loved one should actually urge them on. Am I right? And if you don't quite have that support as well, feel free to share. Our culture really usually only talks about academia and how well you did at this and where you, what wonderful suburb you bought your house, what car you've got. Talk about the real nitty-gritty stuff, and I say this because I've got personal experiences about that as well, you know. There are that many family members of mine that just don't want to talk about that sort of stuff. So, who was the one that had the question? I don't know, are you?
No, I don't need the phone. Oh,
Okay.
I don't.
Sure.
So, do you feel any changes in your bowel that you are going to have a bowel cancer?
No, it does turn into cancer, but what we know is that almost all cancers will come from polyps. They can be quite small, and they can grow very, very slowly, and you may not have any noticeable change while that, if it does turn into cancer, starts growing into the wall of your bowel, and then it can actually then spread throughout your body without you even knowing. So you can quite commonly not have any symptoms, not have any change, you feel perfectly healthy and fine, but have something growing in you. So what the test is looking for is a little bit of blood that even non-cancerous polyps will shed, and it picks that up and says there's something here that needs investigation. And then they go and do a colonoscopy. I don't know if people are familiar with a colonoscopy. It's a very thin camera in a tube that gets inserted up the rectum while you're under sedation, and just has a look through just to see what's going on in the colon and the rectum, in the intestines. And often if they're small, they can just be snipped out. One of the reasons we don't see problems until quite late is because the symptoms that you might expect